We're back with the trauma content, and we're going to do part 2. And as we said, we've done all the components of the primary survey have been completed, and now we're going to do the secondary survey. And the secondary survey is a brief systematic process to identify all injuries, and many different nursing interventions and tasks are associated with each of these. Again, that piece that I had placed, or I will place a piece in your notes. Be sure that you see all the list of the interventions. We don't use the Lewis text anymore, but I still use that one table because it's very, very helpful so that you can see a list for all of the primary and secondary survey, what functions or interventions a nurse will do. We begin or we continue with the alphabet. F is full vital signs, and I think this seems to me kind of a joke because you did respiratory rate, blood pressure, and pulse. You did respiratory rate in the breathing section, you did pulse and blood pressure in the C section, so the only thing left on full vital signs would be a temperature. Okay, so finish the temperature here, and then we're also going to do focused adjuncts and family. G is give comfort measures, H history, and I is inspect the posterior surfaces. In other words, log roll the patient if the C-spine has not been cleared by the healthcare provider. So here we've got full vital signs have been taken, a CT scan of the face, neck, and abdomen are ordered, administration of CT contrast is required for the abdominal CT, and a nasogastric tube is inserted or is ordered, and a Foley cath is also ordered. Versed, fentanyl are given for the pain control and sedation. So I've got a lot of questions here for you. Why is a CT ordered? What is the difference between a CT of the abdomen and a FAST exam? Would you insert the NG tube? And what assessments are needed prior to the insertion of the Foley and after the Foley is completed? Let's look at these in order. So why is a CT ordered? Well, especially an abdominal CT. Anybody that's wearing a seat belt or just the steering wheel itself, because we know that she did not have the airbag deployed, so she could have been up against the steering wheel with not only her chest but her abdomen. But anyway, either of these injuries can cause injuries to organs and blood vessels in the abdomen, and solid organs such as the liver, spleen, or the kidney, well, these are considered that they fracture or lacerate or tear, and they can bleed profusely when damaged. And assessment findings that would indicate that you have bleeding in the abdominal space would be a hard distended abdomen, bowel sounds would be diminished or absent, and of course the individual can show signs and symptoms of hypovolemia, which the initial state would be a rapid heart rate and cool extremities, difficult pulses to palpate on the extremity, which is why we use the carotid pulse. Hollow organs such as the stomach, small intestine, or colon, and the bladder can rupture, and they can spill their contents into the abdominal space, causing peritonitis. So as you perform your assessment, remember to auscultate the abdomen prior to palpation, assess the abdomen for tenderness, firmness, or look at the girth, because again, if you have a massive amount of bleeding into the abdominal space, your abdomen can become distended. So what is the difference between a CT of the abdomen and a FAST exam? And a FAST exam stands for a focused abdominal sonography for trauma. And this determines the presence of blood in the peritoneal space, which is the front side of the abdomen. Now, it can't rule out bleeding in the retroperitoneal space. So if there's any kind of concern that behind the abdominal area that there's bleeding or there's a problem, then a CT is going to have to be needed. And the FAST exam is just something that we used to do this thing called a peritoneal lavage, where we would, it's basically like your peritoneal dialysis. We would put this catheter in the peritoneal space and infuse fluids very quickly and then immediately drain it to see if there was blood, and that would indicate presence in blood in the peritoneal. And that's not really done anymore because of the complications that it can occur, and that's this FAST exam kind of replaces that. If the patient was hypotensive and the abdomen was rigid, then a FAST exam would likely be done because, just like it says, it's fast, and so it can be quickly identified if the patient is bleeding, and then the patient would be rushed to the operating room. That's why trauma center is so important for individuals to go there. But if the patient was stable and the abdomen was soft, then a CT would be more likely be ordered. So, and again, the nursing continued abdominal assessment is very key to this. Well, why wouldn't you insert the nasogastric tube? Well, because anytime the patient has traumatic facial injuries, you have to be strongly suspicious that there's facial or a basilar skull fracture. And this is just a picture to show what one trauma center did. They inserted a nasogastric tube and it went into the brain instead of down into the stomach. And this is because if the base of the skull is fractured, then it creates an opening where the NG tube can go through. So most trauma patients will have what is known as an orogastric tube. It goes in the same place. It just goes, instead of through the nose, it goes through the mouth, which to me would probably be lots more comfortable. Let's talk about assessments are needed prior to the insertion of the Foley and then once the Foley is inserted. Again, because the bladder is a hollow organ, it can rupture and it can spill urine into the abdomen, and that can cause peritonitis. So only insert the Foley catheter if there is no blood that's noticed at the meatus. A lot of times with men, they will do a rectal exam, a digital rectal exam, to ensure that the bladder and the prostate and everything's in the space that it's supposed to be, because you just don't want to insert a Foley catheter into a space that's not there, that's not intact. Once urine is collected, there will be an assessment made for gross or microscopic hematuria, blood in the urine, because of course we want to make sure that the kidneys are not damaged as well as the bladder. Adequate urine output is going to be needed. We want to ensure at least 1 ml per kilogram. I know in your notes, and this is kind of conflicting in my mind, we said really for any kind of shock we want to make sure that we have 0.5 mils. But somehow in some of the trauma literature they use 1 ml per kilogram. Again, I think it's best if you check with Dr. Reed. This is one of those items that you could dispute on the test because, yeah, trauma patients should have 1 mil, but the very minimum they need to have at least 5.5 mils, half a mil per kilogram. And that, of course, ensures that the kidneys are functioning and that volume resuscitation has been done appropriately. Let's talk about the age. That's the history, and we use the ample method to ensure that we get all history of the patient. And the A stands for allergies, M is medications, including the need or whether the need for tetanus prophylaxis. We usually use a 5-year marker if they haven't had a tetanus and there's a lot of facial fractures and lacerations and they've been kind of as one with the dirt. We want to make sure that they don't get tetanus, so they'll use a 5-year and give a tetanus shot if they haven't had one in 5 years instead of 10. Past medical history. With any female, there has to be an assumption that they're pregnant, whether they tell you they haven't been having sex or not, because we all know about immaculate conceptions. So a pregnancy test should always be done before x-rays are done at the pelvis area. Last meal, that's pretty obvious. If this patient has to go to surgery, then we want to know when the last time they ate. They shouldn't be given food or drink at all in the emergency center until it's been a complete evaluation has been done. E is events surrounding the injury. Was there alcohol involved? Was there depression? What is the story with the injury? And then of course take this opportunity to provide emotional support and honest, accurate information to the family. The CT scan of the face, neck, and abdomen are all normal. No bony injuries to the face or neck were identified. No solid abdominal organ injuries were detected. That means the liver, the pancreas, the stomach, or the liver and the pancreas, and that other organ that we have blood, the spleen, goes through, is all okay. However, a right proximal tibia fracture is identified and the orthopedic surgeon has been consulted. Because of this fracture, the patient is at risk for the following complications: fat embolism syndrome, DVT, deep vein thrombosis, and compartment syndrome. And let's talk about why the patient is at risk for either of these three things. Let's talk first about fat embolism. Why is this patient at risk for fat embolism? What is it? What causes it? Anytime there's a long bone fracture, such as the tibia or the femur, then fat globules can be released from the marrow. And these fat globules that are released from the marrow can enter into the vascular space. And so just like air can be there or a thrombus can be there, these fat globules can cause occlusions to tiny blood vessels. And of course, if they go from the leg, they'll go and they'll be released probably into the venous system, and so they go straight up to the lungs. What about DVTs? Well, we know that if she has a fractured tibia, she's going to have impaired mobility, and so that puts her at risk for DVT. Really, if you consider, pretty much almost all of our patients that are in the hospital are at risk for a DVT. And again, because of this fracture, why is the individual at risk for compartment syndrome? What is it? Anytime you have a fracture or any kind of trauma, even if it's a crush injury, edema is going to occur. You know that. Inflammation means that there's going to be edema. And what happens is if it's a very small area such as the thigh or the lower leg, this edema that's created is going to create pressure and occlude nearby blood vessels. And usually because your veins are much more closer to the surface, venous stasis is going to occur first. And when you have venous stasis, that means that venous blood is kind of trapped down into, let's say, that thigh area, and that's going to cause more edema, because you not only have edema resulting from the trauma and inflammation, now you're going to have this blood, that venous blood, that is pooling in this same area. And what happens is you add venous stasis plus the edema that is created. This will then cause pressure on the arterial blood vessels and the nerve. And if arterial blood flow decreases, you know that oxygen delivery to the tissues is going to decrease. The tissue becomes ischemic. Ischemic tissue becomes edematous because those ATP is not made, and so your tissue becomes edematous just from the ischemia, and of course that can ultimately lead to tissue death, which may render the extremity useless or severely impaired, again, especially if the nerve is concerned, or if the nerve is or blood flow to the nerve is compromised. I'm sorry, I'm just kind of Let's talk about the manifestations and collaborative care that's seen with the fat embolism. This was when we have any kind of long bone fracture, such as the femur or the tibia. You've got those fat globules that can be released from the marrow, and they're going to land in the venous system, and you're going to see signs and symptoms of acute respiratory distress. As O2 situations are diminished, then you're going to have altered mental status. Now you're thinking, well, wait, is this occluding? What is it doing? Well, it's because it's causing a venous obstruction. It's causing a problem with your venous, your pulmonary, now artery flow, that is allowing all of that blood that is returning to the heart and therefore lungs to become reoxygenated. So in other words, your venous blood is not reoxygenated, and as it continues to flow, you're going to have a diminished O2. And then what you're going to see is this petechia around the neck, upper torso, conjunctiva, and mouth. And I cannot remember the patho of why the petechia are there, but it's a pretty impressive thing to see, because I had a patient that was in the ICU, and she had petechia around the neck and upper torso because she was originally on the orthopedic floor with a femur fracture. So it's something that you don't forget. But what I did forget was what the pathological reason is. Well, no worries. You have enough to think about anyway. Just know that petechiae are there, and anytime you see petechiae, shortness of breath, altered mental status, you got to think fat embolism, especially if they have a femur fracture or a tibia fracture. What is the treatment? Well, the treatment is going to be aimed at prevention, because once you see a fat embolism, well, then now you're going to have to deal with the oxygenation issues. We want to prevented. So it's very important to immobilize the fracture, because as you not move that broken bone around, then it's less likely that fat globules from the marrow are going to escape. And you want to immobilize the extremity until stabilization or the patient goes to surgery. Provide adequate IV hydration, because again, if we can make sure that the patient's not dehydrated, then you have fewer blood volume, and then those fat globules can cause occlusions. Let's talk about the manifestations and collaborative care for DVT. This is hopefully a review for you, but you know these individuals are going to have DVT prophylaxis. And this is kind of a challenge, because if you think about it, this is a multiple trauma. She's had bleeding into the thorax. She has a potential for bleeding in other places because of a trauma, and then we're going to give her anticoagulation. But it is necessary. It's usually a very low dose heparin or Lovenox, and so bleeding, additional bleeding, is not usually a problem. Sequential compression devices are going to be placed. Again, note that these compression devices have to be inflated at least 20 hours per day, according to the manufacturer, for them to do DVT prophylaxis. And most of us know that when we go in the room, half the time these things are not even turned on. Let's talk about the manifestations and collaborative care for compartment syndrome. I think the biggest thing here is identifying that this individual is developing it. Assess the extremity for paresthesia, numbness, or tingling. Notice that the pain level of the injury or is below the level of the injury. So in other words, let's say that your patient has a femur fracture and they're telling you that, hey, I know you just gave me pain medication 30 minutes ago, but I am hurting even worse, and my pain is radiating down, down, down into my lower leg. And that is really kind of a clue that perhaps they are developing compartment syndrome, and you need to look or assess further. Most of us are kind of a little bit judgmental when it comes to pain, and if an individual has a fracture and we give them a pain medication and then they ask again for pain medication before it's time, we automatically think, oh, potential addict here. So you have to be really, really suspicious, especially when you have an injury that is in the femur or in the lower extremity, and these individuals are at a much higher risk for compartment syndrome, because you're looking at a very small space where edema can make a big difference to perfusion. Pressure and swelling of the areas surrounding the injury. If you see pallor, then you know that perfusion is already compromised. Poikilothermia is just another fancy term for saying that the temperature control is not normal. And again, if you had decreased perfusion, you would expect coolness of the extremity. Note that paralysis and pulselessness, these are other signs of RPs, and these are late and ominous signs. So by the time the individual has loss of function or there is no longer a pulse that's there, then it is most likely too late. You have necrosis already set or already forming, and this is really not a good scene for the patient. What about what should be done to avoid compartment syndrome? Well, as soon as the injury is identified, you want to elevate the extremity, but not above the level of the heart. Again, we want venous to return, but if there is arterial compromise, we want to ensure that arterial perfusion must be maintained. So this is, again, once compartment syndrome is identified, then you're not going to elevate it too high. Before compartment syndrome is identified, then that's when you would elevate higher than the heart, so that you ensure that you don't get that venous stasis that will then form arterial compromise. You want to elevate, elevate, elevate high so that your venous return is returned back to the heart, and it's not just sitting in that injured area. Assess any bandage on the extremity for impaired circulation. Early application is ice packs. That's normal. As soon as we know that the individual has a fracture, we want to put ice on it and elevate it higher than the heart. And that's going to help slow the formation of edema. But once compression syndrome or compartment syndrome is identified, then the ice application must be stopped, because then there's a concern that you have arterial compromise. We do not want to vasoconstrict that artery, which will impair tissue perfusion. This is going to conclude the trauma content module. If you have any questions, please be sure and email me.